All right, welcome everyone. My name is Jenna Johnson, and I'm an academic trainer with the Center for Teaching and Learning. Today's session is titled Culture and Leadership Strategy in Interprofessional Education, presented by Associate Vice President of Duke Home Care and Hospice at Duke University, Cooper Linton. I just want to go over a couple of housekeeping items real quick. Currently, I'm recording our time together. The video is going to be posted on the Center for Teaching and Learning's LibGuides webinar page. Generally, it takes about 24 hours. I do have live transcription enabled. You can turn this on or off by using the icon at the bottom of the Zoom window. And if you have any questions throughout today's session, feel free to use the Q&A forum, or you can use the chat feature. Both of those are also at the bottom of the Zoom window. And I am going to turn it over to Tabitha.
Good evening or good afternoon, wherever you guys are. Welcome to this evening's or this afternoon's IP session. We welcome you on behalf of the Advisory Committee and the School of Health Sciences. We are so excited to have you all with us, and welcome Mr. Linton, who's going to be our presenter this evening. Before I introduce him, I want to just bring your attention to a couple of our upcoming IP sessions that will be held in the next couple of months. On March the 24th, we are looking forward to meeting Dr. Barbara Seymour, Chief Nursing Officer at Sova Health. And in April, on April 28th, Dr. Ann Rhoda from Adventist Health, VP of Mission Integration. So we'll go ahead and get started with our introduction of Mr. Linton this evening. Cooper Linton has worked in the healthcare industry for over 20 years. He has been focused in home and community-based services. His professional background includes strategic planning, healthcare operations, marketing, business development. He's currently the Associate Vice President for Duke Home Care, Hospice, and Home Infusion. Cooper also hosts a podcast, Edge of Aging, around healthcare and aging issues. He has a passion around healthcare, access for the medically underserved, as well as a desire to enhance access for caregivers. Mr. Linton holds 2 masters in healthcare administration and business administration, and he also holds a certificate in gerontology. He's just the greatest in all things. He's an avid hunter. He's an outdoorsman. He's a family man. He's a caregiver. He's just all around awesome colleague. I am so happy to present to you this evening, Cooper Linton. Take it on, buddy.
Thank you, ma'am. And I appreciate an introduction that my mother wished she could hear. She's the only one that would believe it. I'm going to try and share my screen. I did it once correctly today. Let's see if I can do it again. I'm feeling adventurous. Let's give it a whirl. How's that look? Did y'all see a picture of a bear? No, that's good. So this is a quick and dirty. We're talking about culture and its role in leadership. I would actually submit that in the end, culture actually is our leadership. That is our role as leaders in any organization. And I would actually submit that everybody who works in an organization is a leader. I'm not sure what your job is or what you do, but you lead something, and everybody leads culture. I'm going to ask you to be really patient with me and just kind of do an exercise with me for a second. We won't be long, but I'd ask you to just take a moment and think back to a point in your life. Close your eyes if that helps. Some people think that's hokey. Think back to your birthday. It may have been a childhood birthday that was awesome. Could have been the worst birthday in the history of birthdays. Your best teacher, the one that may have actually set you on the course to be in this call on this Zoom this evening. Or reflect on the worst boss you've ever had in your entire life. The one that you still think bad things about. All right. my guess is everybody had an emotional response, whichever one of those you picked out. This, I'm not your priest, so we don't have to have confession time, but there's an emotional response to our memories, and we can't help it. We are beholding to our double helix. We are wired to feel, to sense, to experience. We are unable to separate ourselves entirely from that. For those of you that are Maya Angelou fans, she has many a quote, of course, many a poem that's good, but one of her quotes is that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. She's absolutely correct, or we wouldn't have remembered these experiences. And I'm touching on this because I believe when we deal with culture, we are really dealing with the way people are innately wired. We can escape many things about ourselves, but our human physiology, our human chemistry, our human wiring, well, there's only one way to escape it, but you don't get to do anything after that. So we're stuck with that. We're stuck with who we are. There's an interesting book out called My Stroke of Insight. It was written by a neuroscientist. It was a neuroscientist. She studied brains right up until she had a stroke. And then she began to experience the human brain very differently. And she wrote a book about that called My Stroke of Insight. Take a look at it. But one of the points in the book is that we like to think of ourselves as very analytical, rational, thinking creatures. That we have this great capacity for cognition. And that's what separates us from everybody else. Plus, we've got this cute opposable thumb. That's kind of neat too. But she says physiologically, we're not that. In truth, we are sensing, thinking, feeling, experiencing creatures who on occasion have logical and clear rational thought. And it's an interesting perspective. So I'm going to set that tone. I'll jump in here. I want to do a quick introduction of what Duke Home Care and Hospice and Home Infusion was as a level set as well. So we are a community-based care organization. We serve a 9-county area for home health and hospice, which means we serve 4,400 square miles. And then when it comes to home infusion, we serve 128,000 square miles, all of North Carolina, South Carolina, and Virginia. We're treating about 2,000 patients on any given day. We run a compounding pharmacy where we compound 155 to 160,000 individual doses each year. That plus our non-compounded doses puts us around 500,000 or better medications that we dispense intravenously every year. So I wanted you to kind of have a sense of scope and scale there. And that does mean that we, Veronica, we do treat patients in Spotsylvania. So we cover as much territory as we can. But I wanted you to have a sense of that. We send out nurses, aides, social workers, physical therapists, occupational therapists. We have an array of pharmacists and pharm techs. So that's what we are. We're made up of about 380 people. If we were fully staffed today, we would need 500 folks. There's such a demand for services. So with that in the background, I wanted to touch on, when I think about culture, the order of operations. And some of you may remember that mnemonic, please excuse my dear Aunt Sally, how we tried to remember what to do in which order when we do mathematics. Maybe that was just an Alabama thing, but I swear somebody else had to learn how to do mathematics. So I believe that everything starts with culture. And when we want to talk about organizational behavior, organizational performance, we think often about leadership in a role of having someone there who's highly dynamic, who's gregarious, who's engaging. But I'd like for us to think that ultimately our leader's job is to create a culture. And the culture allows us to create capacity. Capacity in the individuals that come to work, capacity in the way we think as an organization, the way decisions are made. And that capacity creates a space that permits quality. If we don't give people the bandwidth, they will never be able to develop quality. It becomes Lucille Ball at the chocolate factory, where she's on the line and she's trying to wrap these things up as fast as she can. The quality went out the window in a hot second because there was no capacity. Now it's a hilarious scene, but if that's your healthcare, it's not so funny. And so we want to think about the capacity creating the environment that permits quality. And I think most of us would agree quality just never ceases to stop its evolution. We continue to evolve quality. I want to share in a little bit how we do that at Duke Home Care, Hospice, and Home Infusion. And I want to be clear, our leadership doesn't do most of it. Our leadership's job is to create the culture and provide capacity. But the real work happens by empowering 380 leaders. I do want to touch on one other element, a couple other elements related to this before we start talking about how we've implemented this at Duke Home Care, Hospice, and Home Infusion. We talk about mission, vision, and values, and people love to talk about this, and boards of directors love to talk about this, and executives love to talk about it. And then we have meetings about it. Usually you hire an outside consultant to help you put together your mission, vision, and values. And you have 11 meetings, and then you go put it all on a wall. And that's pretty much where it stays. And folks say, well, what's our mission? What's our vision? And usually you can pull a few nuggets out of that. And then they say, well, let's talk about our values. You know, there's so many of the same words used for values. You can Google it and you can get a list of values. You don't even have to think of them. You can just Google them real fast and get all the values you want. And nobody's going to disagree with them because they're common words like integrity. Well, who in their right mind is going to say, I don't want to work for a place like that? They've got integrity and it gets in the way of things. Well, they said, we're going to work on trust. I've not had one person yet walk in and go, I really disagree with this trust thing. All my life, I wanted to work with a place that would focus on dishonesty, deception, duplicity. Come on, let's make this place interesting. Make it more like Survivor or Big Brother, something like that. Nobody ever does that. No one looks at your values and fundamentally disagrees with them. The question is, they don't disagree, but what happens? They don't do anything with them. Most of the time, there's just hanging on the wall, and we don't harness them to turn into the way that we engage with each other in the workplace. My question then comes, how do we harness that and turn it into, what are we going to do? I mean, our culture is largely our brand promise. What are we going to do? And what are we going to be? And when you get to know us, what do you find out? What is the spirit of our organization? So that leads us to this thing I'm a big fan of, besides Guy Clark. If, you know, stuff that works. Sorry, if you don't know Guy Clark, look him up. He's not the world's greatest singer, but he was a pretty good writer. And he talked about things that work, the kind of things you reach for when you fall. Well, I think we ought to have priorities that are so rock solid. When we fall, they're the things we reach for because they help us get back up again. Every organization I've ever worked with has a struggle over what's number one for our priorities. And this becomes an issue with culture. I was in a meeting today. What's our number one goal? Our number one goal is patient excellence. Okay, that's great. Our other number one goal is safety. We also have a number one goal of access for care. We also want to have equity and workforce development and profitability and diversity. Wow. That's a lot of number one goals. And if I'm an employee in that organization, I'm thinking either everybody's in charge or somebody can't count. there's only so many number ones we can have. I personally think there can just be one, but I'm a little funny that way. So the question is, how do we create a structure that operationalizes our values? But beyond that, how does that become permeated throughout the entire organization? Because if we're not living those priorities, if we're not making decisions about how we operate the organization, how we treat the people within it, how we execute the mission, no one's going to believe the values written on the wall. We've got to turn those into verbs. They've got to become decisions. And that's a very difficult piece. And I will say that when our organization went through the process of setting its priorities, it was tough because we had to pick against everything else that wasn't going to be number one. But I would submit that when we don't go through that exercise, we leave it up to all of our staff to try and figure out what's number one today, or what's number one in this meeting, who am I meeting with, and what's number one for them. As opposed to, we have clarity as an organization about what we're doing, how we make choices, how we pick with very finite resources, how we're going to spread out what we do, and then conversely, what we choose not to do. That choosing not to do part is the one where I think most organizations really struggle. So when we set these priorities, there needs to be a healthy conflict of ideas. If there's not, either people don't feel like there's the psychological freedom to share their opinions, or nobody cares. The other option is that we've looked at very near-term goals and no one is really feeling like we've got to play the long game, because in the near term, when there's something pressing like a pandemic, we can all rally around what we need to do. But what happens when that begins to fade and we get back to our normal operations? What's number one? What do we need to do next? There should be conflict in creating the priorities, but the priorities should then resolve conflict about competing demands. So that process of setting them is critical. It's critical for a leadership team to come together, because if we can't agree on what they are, we're probably not going to agree on how to execute them. And if your leadership team is divided, it doesn't take but a hot second for everybody in the entire organization to know it. Because we're thinking, sensing, feeling people. They sense it quickly. They know when there's not continuity and consistency. These are ours. These are the ones that we came to. And it's very important that we put them in this order. Now, I'll share with you that these are not written on the wall. Well, there's probably someplace in the building they're on the wall. We can't help but frame something. But these are on the top of our leadership agendas. Because when we start making decisions, we hold that decision against these priorities. One of my last meetings today, we had an issue at the office, and I said, my question is, how did that behavior stack up against priority number one and priority number two? These become incorporated into the way we think, the way we operate. And they're important enough to me personally that I meet with every new employee in orientation in the first hour and go over these so that they understand, probably before they figured out where the restrooms are, what the decision priorities are for the organization. But we also talk about why. We could hand these out on an index card and they'd have them. We can put them on the back of their badge. That's great. I don't want them on their badge. I want them to understand what these are and why we do them. Because if we're going to ask people to be problem solvers and decision makers, this needs to be almost branded. This becomes the brand for our organization. For us, it's about access to care now. We believe to the core of us that if someone gets care somewhere besides our organization, their care won't be as good. And for the most part, the data supports that. That doesn't mean we don't have good days and bad days. But if we're saying no to somebody, we're relegating them to care that isn't as good. And that's hard to go home and feel good about at night. So we talk about saying yes to care now. To increase excellence in patient care and awesomeness in service, we make a distinction between those because I often have no idea what happens to my body in healthcare. But I know how I was treated because I'm a thinking on occasion, but always feeling, sensing, experiencing person. I know how I've been treated. Back to Maya Angelou. I know how you made me feel. I may or may not know whether the pharmacist put the right drug in that bag, but I know whether you were kind to me. We talk about proving value in dollars, days, and capacity to our health system. It's a little inside baseball for Duke, but that essentially means that we want to be masters of our value proposition more than servants to our revenue line. There are times we're going to make the wrong financial decision for the right reasons, and we justify it through the value proposition back to the system. The fourth item is we're going to make buck when we can. That doesn't mean we don't like to make bucks. We do. We've got to put it in the right order. Because if we make money doing it the wrong way, we failed. So we go through these with our staff, again, in the first hour of their employment. We also spend some time preparing them to participate in our lean processes. So I want to touch on that. For some people, lean processes are yellow sticky notes in a room and everybody goes in, they have 3 days of rapid cycle training. And about a month later, nobody remembers what the heck happened. Other than you paid a consultant for 3 days of lean training. We decided we could do this in home and community-based care, and very few organizations have done this in home and community-based care. It's been done a lot in hospitals, done a lot in clinics and surgical centers. But in the world of home and community-based care, it's considered rare. In fact, most of the time it's considered non-existent. In fact, it was so unusual that we partnered with an outside consultant and it was a handshake agreement. You're going to teach us about lean. We're going to teach you about home-based care, and we're both going to come out of here better. We needed to figure out how to solve problems permanently. And we needed to engage our frontline staff in doing it. It needed to be supported from the top down. But everything that's accomplished is bottom up. As leaders, we're prone to a culture where we make decisions. We guide discussion. We're the problem solvers. We know things. Well, I've got a couple master's degrees and 25 years of experience. I ought to know something. But it turns out, when it comes to the frontline work, I don't. I'm not good at that work at all. So how do we engage those people and liberate them and empower them to make decisions? So I'll start with kind of how we got into that. One of the fundamentals was a fundamental respect for the people's time. People talk about they don't have a work-life balance or they're exhausted when they go home. Have we respected their time? Time is our commodity of exchange, but the only way we can deal with it is trust is the currency of our exchange. We had to build a deep sense of trust in our organization. I'll share with you that the first time I ever walked into our inpatient facility, I'd been at Duke only a few weeks, and I decided to, well, it wasn't the first time I'd been, excuse me, it was the first time I'd been at night. I walked in, it wasn't very late, 9:30, 10 o'clock at night. And a nurse comes down the hall, and I let myself in through the employee entrance. I'm wearing a badge. A nurse comes down the hall, and I said, "My name's Cooper." And she goes, "Yeah, what's wrong?" I said, "I have no idea, but I'll pitch in and help if I can. But by the way, what's wrong?" She goes, "I have no idea what's wrong." I felt like I was an Abbott and Costello who's on first. I said, "Well, I'm sorry. I think I'm at a disadvantage in this conversation. You're convinced something's wrong and I don't know what it is." She goes, "Oh, I know something's wrong because folks like you aren't here unless there's something wrong." Okay, she's right. There's something terribly wrong. We needed to start establishing trust to where when someone like me, which I think that meant a guy in a sports coat, walks into the building, that the anxiety level doesn't go up. Because as soon as that anxiety level goes up, we no longer have a culture of trust. And that culture of trust is fundamental to being able to solve problems. What if he catches me making a mistake? My response is, what if you catch me making one? The odds are pretty good you're going to catch me making one. I'm good at it. Got 25 years of experience breaking things. Promise you can catch me. The other idea is a fundamental belief in a commit to zero. What does that mean? Everybody phrases it a different way. This is Duke language. The idea is no one should be harmed in the delivery of healthcare. Whether they're receiving healthcare or they're delivering healthcare, they shouldn't be hurt. Or as one guy I worked with said, "For the love of Pete, don't hurt nobody." All right, fair enough. If we went into the day with the concept of don't hurt nobody, we would be heads and just far ahead of most organizations when you look at the number of errors, mistakes, and harms created. We don't want to address problems. We don't want to meet about problems. We want to resolve them forever, and they never come back again. That's our goal. So we started looking at, so what's harm to begin with? For us, we looked at patient harm, obviously. Someone gets hurt, wrong drug, someone gets dropped, mistaken identity, all of those things. Same things everybody's familiar with. What about emotional harm to the family members and loved ones? And I use the word family member loosely because who I define as my family turns out not to show up on Ancestry.com. There are people I love as family, but I don't think we're sharing genetic material. What about our staff? What about their psychic well-being? What about their physical safety? What about the organization? Are there harms that happen to the organization? There shouldn't be anyone harmed. Very simple. We talk about good catches or near misses. I simplify that in my mind. Those are simply harms that haven't shown up yet. They're coming. Statistics tell us we have enough near misses, one of them's not going to miss. So we treat those actually as harms. Treat them as if they become harms. That has worked for us, but it's hard to do that in a community-based care environment. In fact, some folks have said you can't do it. And I would differ that you can't. I would say it's very different and it's very challenging. We put in safety huddles and tiers. Now, that's no different than anybody else, but ours are entirely virtual and our staff are scattered over multiple counties, often doing it from their cars and their sidewalks and their kids' soccer games, wherever they are because we have a dispersed workforce. But we capture everything in these huddles, and we have a different idea of what harms look like. We also capture people who get caught doing things awesome. And we'll call you out. If you get caught awesome, we're going to put a light on you. People enjoy that part a lot more than they enjoy reporting the harms or the near misses. One of the challenges we created, though, is that culturally we had to shift in our leadership role. I go back to this culture is leadership. Our leaders had to quit having 2-hour management meetings. We have shifted our management meetings to 15 minutes, and we've cut 70% of them. You know what's not happened? Not one person's come into my office and gone, Coop, man, I really miss those 2-hour meetings where we didn't do anything except think about what we weren't doing while we were in that meeting. Can we put those back in? Hadn't happened yet. We turned out some of the meetings could be replaced with an email. We double checked, we made sure emotional safety, queried everybody on the director's team. It turned out they were all literate. So we started sending emails to people, and they read them. Didn't even have to read them to them. We don't send pictures out anymore, just letters. Works great. We've eliminated 70 to 75% of our leadership meetings. Not because we don't meet and get things done, but we move on a cadence that's completely different. We have tiers every day. 15 minutes on Monday, Wednesday, and Friday is added to those meetings. We rarely use all 15 minutes. But 3 times a week, we have the opportunity to meet for 15 minutes. We're done in less time than that. What has also shifted is when an employee brings an issue, escalates an issue for us to resolve, we don't put it on an agenda, send it to the administrative assistant who puts it on agenda, who puts it on the calendar so that 2 weeks later we can talk about it, but we can't remember what it was in the first place because it was 2 weeks ago. We don't do that. Our job, if there's an issue that's escalated as a leader in our organization, I don't care what's on your calendar. It's not on your calendar yet anymore. Our job is to support the needs of our frontline staff. Well, I have a meeting at noon. No, you had a meeting at noon. Now we have to take care of our frontline people. And that's a shift in the way we have to think. We can't just talk about it. Our calendars have to change. Our work cadence have to change. And the fact that we get to know our people and our people see us as problem supporters, not necessarily solvers, but we support them, changes our dynamic entirely. We become a resource for our people. And nobody minds when you knock on the door at 10 o'clock at night and walk in because you help them get stuff done. This is an example. The one on the left is a physical huddle board. I think that one is from our inpatient hospice facility. Doesn't matter. They all look alike. If you've ever seen a huddle board, I don't care which hospital you went in, which facility you've been in, they all about look like that one on the left. The one on the right was our first effort to make this digital. So what did we do? We replicated the physical one. Turned out that didn't work at all. But we fail forward and we fail fast. So it turns into something like this. This is nothing more than a smart sheet. We run through this very quickly. Tier 1, Tier 2, Tier 3. Tier 1 is all of our frontline staff. That may be the person who coordinates a referral, a nurse that meets with a family member in the hospitals, the nurses in the field, the therapists in the field, the pharmacists. It doesn't matter. That's all frontline to us. They do different tier 1s because we've got to split the world up a little bit. We can't have 87 people on one call, though you can try. It's amazing how much problem solving happens in 15-minute huddles each morning. The issues in tier 1 get escalated to tier 2 and consolidated. This particular process means we have a running tally of every issue, every harm, every concern we have. By the time it gets to tier 3 starts at 10:30 every morning. It doesn't start at 10:31. Respect for people's time. And people say, well, do you run tier 1? I mean, tier 3. Sometimes. We actually rotate it every week so that every member of our leadership team runs tier 3. Everybody needs to be able to run it. And if somebody takes me out in the parking lot and shoots me, we ought to be able to run just fine tomorrow. Somebody else knows how to do it. And a couple times that first idea has been suggested. A couple folks started walking me toward the parking lot and I got nervous. But we have a backup plan. And so The idea is that we run through this data, and this is a tier 3 from back in August, so summer of this past year. We know our harms. We know how many admissions we've run. And it says admissions over 2 days. Why do we track that? It's 1 day for hospice, 2 days for home health. We believe that any patient that isn't admitted that fast, unless it's at the request of the family, is at risk for readmission. Their harm risk has gone up. We call them out. Anything that's in that column has to be explained in that meeting. It's not punitive. We need to understand why it happened. Is it a systemic problem? Or did Ms. Johnson say, I'd rather be admitted tomorrow, thank you? It's fine if that's a Ms. Johnson issue. It's not fine if we cause Ms. Johnson to be admitted tomorrow instead of today. We have to own that. We may have put Ms. Johnson at higher risk. We want to know how many patients, this one has COVID positive patients, PUIs, what's our census, how many admissions we've had, were there any line infections for us, what are our capacity challenges? We break them down by geography and by discipline. We should know exactly where our pain points are, where our staff's pain points are, and the delivery of care. Did we have any good catches? Did we have any celebrations? It's a little different when you're looking at home infusions, a little different when you look at hospice, but conceptually, it's very similar. The point in all of this is that we have this granular review on a daily basis, and we cover 2,000 patients in 15 minutes. People say you can't do that. Can too. We can. But it requires a discipline, and it took us a while to get to this point. When I say it took us a while, it took us almost 2 years. It's not easy, and it's incredibly uncomfortable. And you've got to admit to all the people you work with that you actually don't know what you're doing most of the time. That's a cultural piece of, is there the safety to do that? And does our staff know that we're going to throw ourselves on a spear to take care of them while they take care of our patients? How do we feel to our staff? How do we feel to our patients? Culturally, what does this say about us? So I've spent over 20 years working in hospice. I've seen a lot of people die. You start thinking about how you might die. My goal to you, for commitment to you tonight, is you will not die a death of PowerPoint. This is my last slide. I will ask you to think about what is your personal culture. People say, I don't know what you mean my personal culture. You mean like how I was brought up? Well, maybe. I'm asking you your personal philosophy. If you had to turn your philosophy for yourself into priorities and pick for and against what's number one, what would it look like? How would that turn into your brand, your personal promise and commitment to the people around you? How would that inform how you lead? We spend a lot more time talking about how we lead than how we follow. We like talking about how we're going to lead. That gets exciting. We don't spend as much time talking about how are we going to follow. We're all following somebody. Probably a lot of somebody's. Personally, I'm following 380 on any given day. Plus, I've got a boss. Most of you have experienced work somewhere. You might still be thinking about that boss I brought up early on, the one you can't stand. You're probably thinking about what you can mail him for Christmas. But it may teach you what culture you don't want. Now, my question is, what culture do you want to create? My other question to go with it is, what are you willing to sacrifice to make that happen? We really struggle as organizations to use the word sacrifice. Acceptable losses. What are we willing to give up to obtain the culture that we want to create? I believe fundamentally our culture defines what people experience, what we achieve, what we don't achieve. And if we're not really careful, or if we are, our culture will define us. At some point, if we do this well, our culture gets bigger than the people that said it, and it takes on a life of its own. And it begins to lift us to places we didn't think we could go. I'm out of slides, y'all. And so if you don't mind, I'm going to stop sharing. And I was hoping maybe we could open it up for some discussion, or however you'd like to carry this forward. This is your event, not mine.
Awesome. Thank you, Cooper. Awesome, awesome. We will go ahead and open up for a Q&A at this point. Wow. I have a host of questions, but I will not dare spill the floor at this time. I will allow some of our participants to take the time to ask questions either via the chat and or live. Unmute and ask questions if you will. We will be happy to hear from you as well.
Wish I had my team members on. They're better at answering questions than I am.
All right, I'll start off. Listening at all of this, Cooper, the engagement with Duke staff and getting them to collaborate in this shift in leadership, the mentality, the mindset. What was it like? What impact did it have on the patients? The outcomes. What did that look like? What did that feel like for the patients? I'm just trying to envision what that feel was like for them.
So what we have found is that our quality of care actually in all three programs has gone up. And it's gone up precipitously. It's gone up wonderfully. It doesn't mean there aren't areas that we go, yeah, we still need to fix that, or we didn't do a great job, or why is that one area off? In fact, I was in a quality meeting going over home health scores this week. Every single quality indicator was taking off, except for one. And that one really stood out because it was the only one that wasn't moving as fast as the others. And we spent most of our time looking at that. Well, we didn't look at it in a way that's punitive. Well, who's screwing up that metric? It's not the point. I haven't seen any of our 380 people show up to work and go, hey, it's Tuesday. I've got 4 whole days to mess stuff up. It just doesn't happen. They're wanting to do the right thing. But we need to create the environment where they can. And we realized we needed to provide some resources to our staff to move that one metric. But overall, everything has gone up. Our patient satisfaction has improved. Interestingly, our turnover, which this began long before the Great Resignation and where before we couldn't find nurses, our nursing turnover was cut by over 50% in 6 months.
Mm. And
we will say, well, what's your return on investment? Well, what's saving that many people in your workforce costing you? And you can cut it any way you want to. It costs you $100,000 to bring a nurse on. People say, no, it doesn't cost that much. Okay. It costs you $100 grand and it might cost you more. So when you start calculating your turnover, and I will say this, if we reported on our P&L a loss of $100,000 every time we lost a key employee, and to me, a key employee is not necessarily a leader. Anybody who's impacting our mission is a key employee. We would look at it. If we got an expense every time we lost somebody, we would change the way we thought about treating our people. We need to create the hidden cost P&L, the cost of the volume we didn't take, the cost of the patients we turned down, the cost of the people that we lost, the cost of the applicants that didn't join us. Lily, and I don't know who you are, but you're a home health administrator. So thank you, ma'am.
All right. Let's see who we have in the chat. All right. Any other questions?
Looking at the questions, this has been an amazing presentation, Cooper. So there's been lots of comments of appreciation for sharing your wealth of knowledge. One of the questions was, how do you constructively call out your boss on his failure to build a culture and enforce the organizational, or failing to exhibit the organizational values? You're talking about changing culture, but what do you do when your higher ups don't necessarily display those same values?
So typically we like to engage in that by yelling and name calling. We find that to just open the door immediately to receptivity. So I think part of it is I typically want to ask questions. And with a rare exception, I've never had a boss that really thought about how they were perceived. One of my favorite poems is Robert Burns' The Louse, and the first three lines of the last stanza are, "Oh, the power to give us to see ourselves as others see us, and from a many blunder free us." I think many times we simply don't realize how we're seen. And I say that as someone who's been called out on it, and accurately so. It didn't feel good to be called out on it, but they were right, and I needed it. I think most of us, when we're called out in a way that says, hey, I don't know if you knew how that came across to some folks. Today, I had a conversation with a colleague who was trying to coach another employee, and they said, I don't even know where to start. I said, ask them if their customer's perception of them matches their perception of themselves. And maybe it does, but I bet it doesn't. And so that's typically how I would approach it. And unless you just truly have a jackass for a boss, and if that's the case, it's the Great Resignation and Duke's hiring. So
one of the other questions was, have you considered advertising your open positions to nurses who are leaving the bedside due to poor treatment? So it sounds like you've got a great company working and great environment. So that would be a thing to come to Duke as opposed to elsewhere.
We are. One of the things we find is that a lot of bedside nurses love the idea of care in the home, but it's intimidating. There's no environmental services. There's no security. You're going to have to move in a world where you're largely independent and at high scope, top of practice, or high top of scope of practice. Because of that, we realized we needed to change the way we orient our staff. A lot of organizations will put in 8, 10-week orientation. Some will do 12. We run a 21-week orientation. And also, one of the things that happens in the first 1 hour that someone is there, our senior nurse meets with every employee, whether they're a nurse or not. And each one of them is given a white flag on a stick. It's the same kind of flag you'd see if you were marking your irrigation line in your yard. It's nothing fancy. We pick them up at Lowe's. On that white flag is also our senior director of operations, ACNO's cell phone number. If you get to the point that you're not sure what to do in your onboarding and you're like, I'm being overwhelmed, hold up the white flag. Don't leave. Just hold up your white flag. Our job is to support you in your career. I want you to call us and we're going to help you. What does that mean? I can call my boss's boss's boss to get help? I actually can call her at home. That's her cell number. Yeah, that's what that means. We have to back it up. And yes, we are trying to advertise to folks that way.
Awesome. Trying to follow check. Did we get this one here? How did you get the leadership team to buy into humbling themselves to treat their subordinates with the great respect or to care how they really feel?
It varies. Different people walk into the room with different emotional intelligence. Again, not everybody sees themselves as others see us. None of us ever do, right? Because we sense our world. We don't always sense your world. I don't know what everybody else on this screen is experiencing right now. So I can try and take an estimate, but I guarantee I'll be wrong for several people. So how do we do that? For one, I think most of us are a lot more aware of our shortcomings than we want to admit. And the question is, do we create an environment where we can talk about it? And that means I've got to sit in front of my team and say, hey, I owe you an apology. I totally misunderstood what you said in the meeting and I botched it. I'm sorry about that. When was the last time you heard people say they were sorry and meant it? When was the last time leadership admitted when they were wrong? We talk about courageous candor a lot. In fact, when I first came to work there, we set the tone with listening tours and talked about courageous candor. And one of the folks said, okay, I'm nervous about you being our leader because you came from our competitor. And I hear you can be mean. I said, you're right. No, but I said, I appreciate your question. I think if I were you, I'd be a little nervous about it too. Let me tell you why I came. And I shared with them why I came. And did they walk out of that room instantly with trust for me? I don't think so. But the next day I see them, and a week later I see them, and time builds trust. And that trust thing, we walk in the door, we ask people to trust us. And I guess my question is, on what grounds do we have a right to expect their trust? Have we earned it, or did we just ask for it? More relevantly, do we feel entitled to it? Why should you be entitled to trust? What have you done to deserve it? And so from a leadership perspective, we had some tough conversations, and our leadership team had to build trust within itself first. One guy walking around shaking hands with folks is not going to ring the bell. And our leadership team had some tough days. We had some tough conversations. And we drank some beer. Or where we had to have some after hours chats. Gloves off. Hey, man, I got to tell you, I'm not sure you and I are okay. Well, maybe we are, maybe we're not. You go first. Tell me why you're not. And we had to walk through it. And it wasn't easy. Humans are messy.
One thing that's unpredictable, and that's human behavior, that's for sure. Any other questions? I know we're getting close to time, and I want to be respectful of that. I don't see any additional questions in the chat.
There was one more question.
One more,
Sheila
okay.
asked, what has been some of the most challenging parts of providing in-home care during COVID-19? Because you kind of gave the general difficulties, but has there been anything specific with COVID-19?
Yes. One of them is the very predictable. It's a great question. Thank you. And one of them has been trying to manage a pandemic in an environment where there's not environmental services, there's not control of the buildings, they're not ADA compliant, nothing is set up for patient safety, it's set up for the comfort of your home. So that's one of them. We had to teach our staff to don and doff very differently than they'd been trained in the hospital. We had to ensure access to different types of PPE that are more adaptable to the home environment. You can't walk into people's living rooms wearing a PAPR. That's not the real world, but I also can't have staff going home infecting their children either. So we had to have a lot of training around it, some false starts. And that was one piece. The part that I was not expecting, and if I was a better studier of human psyche, maybe I should have, but as people's anxiety went up, their fear went up, and their behavior self-control went down. And so we began to see and continue to see increased unrest in homes, violence in homes, untreated mental illness. I'll tell you, a month and a half ago, 2 of my staff members knocked on someone's door for an admission. And when the door was opened, and of course they called before they came, when the door was open, they didn't meet a patient. They met an agitated, angry son, but they couldn't see his face because he was hiding behind a rifle. They were looking down the gun barrel and the guy's fingers on the trigger. Now, we didn't have a tragedy that day, but we were that close to a tragedy that day. So we have seen escalations in that, and we're trying to find ways to do it. And again, that first hour of people's experience, the number one thing I tell them is we will never second guess your judgment. If you walk out of a house, you were right. And if I have to apologize to a family for your rudeness, I'll take that over apologizing to your family that you're not coming home. And they have to understand that you never second guess somebody. If their instinct tells them something's wrong and they walk out of that house, they were right. And we will never question it because nobody has the authority to experience what they experienced in that moment. We will find a way to do it right. I saw a quick question come through about remote patient monitoring. Yes, we do telemonitoring. We have a number of units out, and we also use a product called Doximity. So we monitor people that are hooked up. We can monitor their vitals and things like that. If they're high risk patients, we have a nurse that monitors a dashboard on that. We also utilize a product called Doximity to make telehealth visits where I can send a patient, well, somebody who's smart can send a patient a link, they can click on it, and anybody with a phone can have a telehealth visit. I mean, come on. If my son can Skype with his girlfriend, there's got to be a way for us to deliver healthcare across miles, right?
Stop calling about Google. Awesome, awesome. Well, we're right at the hour here at 7:50. We have 2 minutes, and I appreciate everyone's participation. Cooper, we thank you so much for your information, your knowledge. Thank you for sewing into us this evening. We look forward to engaging with you hopefully in the future and sharing more information and wisdom with us. We appreciate all your participation, all the participants that joined us. We ask that you continue to join us in our future webinars that's coming up, IPE sessions in March and April. Dr. Seymour is coming up. We have Dr. Rhoda as well. We're looking forward to those as always. Please look at us in the comments. You'll be getting email alerts, blasts. The surveys are out from registration for this presentation. Please fill them out. Let us know how we're doing with these IPE sessions and webinars, how we can, sew into you in the future. Thank you all very much for your time, and we look forward to talking with you very soon. Take care.